Now that you're a little more familiar with some of the tests that we might do throughout a pregnancy, let's talk about the actual physiological changes in pregnancy. The body makes lots of adaptations as the pregnancy continues. Some people have referred to pregnancy as being a third gender because the body does change in so many different ways. In this audio lecture, we're going to go through some of these different ways. When you are in class, we're going to practice, put them together, and see how they would impact our risks and our benefits, and how they would impact simple common discomforts. First, let's talk about our reproductive system. This is kind of a duh, right? Obviously, pregnancy impacts the uterus. It enlarges up to 20 times its original size. How crazy is that? Imagine if your heart enlarged that much. Ovaries change because of high levels of placental estrogen and progesterone. Obviously, they don't need to ovulate anymore. The vagina itself becomes softer. There's more mucus produced. There is more blood flow to the vagina. And the actual pH of the vagina changes. It becomes more acidic to help decrease risk of infection. Breasts change. What kind of change is that? That is a presumptive sign of pregnancy. They can increase a little in size because of preparation and changes in the milk ducts. They can become full and tender. Remember Goodell's sign and Chadwick's sign, both probable signs of pregnancy. Those things change because of hormones. The musculoskeletal system is impacted significantly. It is impacted by hormones. Relaxin is a hormone that relaxes. How about that? A name that makes sense. Enjoy it while you can. Relaxin actually softens the cartilage in the pelvis, so it is able to adapt, potentially move a little bit more in the labor process. It helps the symphysis pubis actually become a little bit wider, enabling that pregnancy to drop when the time comes. Remember that uterus to sink down and become a little lower. Have you ever seen a pregnant woman waddle? If you have, I hope you have not used that term. The technical medical term for that waddling gait is a pride of pregnancy walk. You can kind of see women tend to sway a little bit because of both the relaxin and the change in their center of balance as that uterus becomes bigger. That change in the center of balance can be an issue with her balance, especially if she wears heels. She needs to be aware of that. Lordosis is an adaptation of the body towards pregnancy. You can see in the picture here the exaggerated lumbar curve as the weight of the uterus, not seen in this picture, but picture the weight of the uterus here pulling forward and down. That might cause some lordosis. If you have a patient who has had back issues in the past, she may be impacted a little more severely by this musculoskeletal system change. Going to cause some increased back strain. It's not an uncommon complaint in pregnancy. The cardiovascular system makes quite a few adaptations throughout the pregnancy. One of the most significant is that your pregnant mom's blood volume increases by 30 to 50%. Usually that starts in the second trimester and is at 30 to 50% close to the beginning of the third. Because she has this extra blood volume, her heart has to work a little harder to get it through. So her heart rate is going to increase by 10 to 15 minutes or beats per minute as well. This increase in blood volume and pulse rate is going to help the uteral placental blood flow and get that oxygen and nutrients to the placenta where it can nourish our fetus. Clotting factors increase. The good thing about this is it helps prevent hemorrhage, which is our biggest concern at delivery and throughout pregnancy. However, the downside to this is it also increases your mom's chance of a DVT or other clotting disorders. Our red blood cell mass increases. As that blood volume increases, the plasma portion increases faster than the actual hematocrit and hemoglobin. That's going to cause a physiological anemia. We're going to talk about that in a bit. You might think because this patient has more blood volume, her heart rate is faster, that her blood pressure would go up. It actually should remain unchanged, and that is because of the progesterone. That progesterone hormone is helping things relax and dilate, So those blood vessels are going to be able to relax to accommodate that increase in blood volume. Her blood pressure should never increase. That is never normal. The result of all of these changes means that you have between 500 to 1,000 milliliters of blood going to the uterus every minute. Picture a full bag of IV fluid. That's how much blood is going through your uteral placental circulation to keep that fetus oxygenated and growing. The potential risk to this is if that placenta does tear away or you have issues with bleeding in the pregnancy, you have a potential for your patient losing 500 to 1,000 milliliters of blood per minute. This is why hemorrhage is our most significant risk in pregnancy. In a normal pregnancy, the blood volume increase and the other changes compensate for the blood lost in a normal delivery. Another potential problem for your patient is supine hypertension. We're going to talk about that here in just a bit as well. Keep in mind that your pregnancy values are going to change. Because you have more plasma, your hemoglobin and hematocrit will actually decrease in their lab value. So even though she has more blood, her H&H will decrease. Every lab facility may have slightly different normals, but this is to give you an example. A non-pregnant hemoglobin is usually around 12 to 16. A pregnant patient's normal hemoglobin level is going to drop just a bit. Same with the hematocrit. And an interesting change here, her white blood cells values will change as well. She can be anywhere from up to 20 of the white blood cells. Not necessarily an infection, it's just that her immune system is changing because of the pregnancy. This change with the H&H is called hemodilution of pregnancy. That is an important thing to remember when you're looking at lab values. Why is supine hypotension a problem? Remember this picture? As this fetus gets bigger and bigger, that is more and more weight potentially pressing on her aorta and vena cava. So if she is on her back, she has decreased circulation, and then she suddenly sits up or stands up quickly, she can get a little bit of a supine hypotension, feel dizzy and lightheaded. Important to teach your patients, first of all, to always have a little bit of a tilt, and secondly, never make rapid motions up and down. Take your time getting up. This is another good visualization of how that compression can press down and decrease circulation. Very easily fixed, just tilt her to one side or the other. Textbooks usually say the left side because physiologically that's going to give you better blood flow. If your mother's more comfortable on her right, I wouldn't make a big deal about it. The important thing is to keep her off her back. The respiratory system changes as well. Obviously, she's going to have increased oxygen demands because she is breathing for two. But her oxygen consumption actually only needs to increase by about 20%. And again, those hormones and changes are going to adapt and make that possible. Dyspnea is common, primarily caused by an increasing uterus that is pushing up into her lung space. In order to accommodate this, her rib cage is actually going to widen and her respiratory depth increases. As well as those changes, she usually is going to have some nasal stuffiness. Some pregnant women complain about their noses looking a little bigger. Again, this is hormone related. Progesterone slows things down, relaxes blood vessels, so she's going to feel a little bit more stuffy in her nose. It is also possible for her to have nosebleeds, primarily in the second trimester. This is one of these symptoms that is caused by estrogen. The increased estrogen level in the second trimester, as the placenta really starts to grow and produce its own, makes it more likely for her to have increased vascularity, which can lead to nosebleeds. That estrogen starts to decrease in the third trimester. So as she hits the third trimester, nosebleeds should not be a problem, and if she were to have them, I might be concerned about platelet levels or clotting issues. The gastrointestinal system. This is the cause of many of the normal complaints of pregnancy. Again, estrogen, increased vascularity mean her gums might get a little red and swollen. They have actually linked bacteria in the teeth to preterm labor, it is very important that she gets good dental care during the pregnancy as well. Nausea and vomiting occurs in at least 50% of women. It's very common in the first trimester. The theory is that it might be related to a sensitivity to HCG, but we're not 100% sure about that yet. Delayed gastric emptying. Guess what causes that? You got it, progesterone relaxes, slows things down. That's a good thing if you want a relaxed uterus and relaxed blood vessels, but it can also lead to some heartburn. Decreased motility, again, progesterone also causes constipation, which can lead to hemorrhoids. It is not uncommon for pregnant women to have issues with their gallbladder. You will see women in triage come in with your classic signs of a gallbladder attack. When you move to med-surg, you might notice women who have very recently delivered a baby on your floor because they just had a cholecystectomy after they had the baby, related to increased gallstone formation because of the prolonged emptying time. And of course, increased thirst and appetite. We'll talk about the nutritional needs in pregnancy towards the end, but she is going to be a little more thirsty. Once the nausea and vomiting goes away, she may be a little more hungry as well. The urinary system has some adaptations to make as well. Frequent urination, or frequency, is very normal in both the first and the third trimester. It is not normal in the second trimester. Urinary stasis, because the progesterone relaxes things, means that circulation doesn't move quite as quickly, which means she is more prone and likely to get urinary tract infections. She is also more likely to have a trace amount of sugar. Bacteria love sugar, so there's another increased risk for urinary tract infections. UTIs are one of those underlying potential risks of pregnancy. If we catch them early, you can treat them. Hopefully it's not an issue. But pregnant women are susceptible to infection, and I have seen more than one patient end up very quickly in the ICU with a UTI that turned into a bladder infection that got out of control. We want to be on top of this. Why does she feel like she has to pee in both the first and the third trimester? This is a great visualization of why that is. In your first trimester, the uterus changes position. There is a very small zygote in there, but the uterus itself moves forward, pressing on the bladder, which is why even though she doesn't look pregnant, she feels like she has to pee because that uterus has changed position. As the baby continues to grow, that uterus moves up, is growing in the second trimester, and moves off the bladder. Suddenly the frequency is relieved. The second trimester is noted to be probably the most comfortable part of pregnancy. Many of your symptoms go away. But as the third trimester begins and that baby starts to grow significantly, many of those symptoms are going to come back, among them frequency, because now the weight of the baby and the uterus itself are pressing forward into the bladder. I want you to keep this picture in mind for a few reasons. If you see your bladder here, when we start to talk about women going into labor, our goal is to have a baby come out. If I have a full bladder right here, it's pushing the uterus to the side. It's not going to leave the baby as much room to come down. So just looking at this picture, a little note in your head, think about how important it is to have an empty bladder during the labor and delivery process. Also important, once that baby is out and gone, to keep that bladder empty so that the uterus can compress and tighten like a muscle should. If the bladder itself pushes the uterus out of its spot, it won't be able to tighten and you'll have an increased risk of hemorrhage after delivery. So lots of reasons, both during labor and after labor, to keep the bladder empty. In the third trimester, she's going to feel a lot of frequency related to the weight of the baby. So she'll be in the habit of going to the bathroom frequently. Integumentary changes. The skin does change, and we talked about some of those. Striae gravidarium, linea nigra, melasma. Be able to define those, know what they are. Another change in pregnancy has recently started to gain more recognition and importance, and that is that we are realizing that the immune system itself changes significantly during pregnancy. This has some advantages and some disadvantages. The inflammatory response is increased. You have lots of changes in hormones, you have lots of actual physical changes from the growth of the baby. That's going to increase your inflammatory response, which is probably involved in that normal increase in white blood cells. Her adaptive immunity is decreased. Now, the advantages to this mean that the mother's system is less likely, it's not going to reject the fetus as a foreign body. That's a good thing. The disadvantage is that because the immune system isn't as functional as it once was, she's at an increased risk of infection. And the areas we usually see this in are UTIs and flu during the flu season. Because she's at an increased risk for infection, when those infections do happen, she is also at an increased risk for sepsis, which is life-threatening and needs to be taken and addressed very quickly. This change in the immune system impacts autoimmune diseases in different ways for different patients. But if you have a patient with some type of autoimmune disease, you need to be aware of how her pregnancy is going to potentially change that as well. It's not uncommon for asthma to actually improve throughout pregnancy. However, things such as diabetes and lupus frequently flare and have more problems during pregnancy because of these changes in the immune system. The endocrine system. Here's the heart of pregnancy. Hormones drive everything. The interesting thing about the placenta is that in addition to becoming a respiratory organ for the fetus, a nutritional metabolic organ for the fetus, it also actually becomes an endocrine organ itself and produces a large amount of hormones. The first trimester, there are usually changes in the pituitary and thyroid gland. By the second trimester, the placenta starts to produce its own hormones so that drives the other changes needed as that baby grows. Because she has all these changes, it is very common for pregnant women to feel warmer than everybody else in the room. Frequently they feel hot, which is not a good thing in Arizona, but might be a good thing in Montana, right? This is related to vasodilation, and also she's carrying around her own little heater. The fetus actually produces heat as well, and that's going to keep her warm. As mentioned, the thyroid gland gets larger. Her actual metabolic rate increases by about 25%. Oxytocin, also called pitocin, and prolactin are secreted by the pituitary gland, and these are going to drive some of those changes in pregnancy as well. Please pay attention to this slide. You need to be familiar with how hormones are going to impact changes in pregnancy, which is going to impact her risks throughout the pregnancy and delivery. We know she needs estrogen. It increases vascularity, which helps that fetus, helps everything implant. It helps everything grow. It increases circulation. It's a problem if we don't have enough of it. Progesterone, however, is probably the most important hormone for early pregnancy because it relaxes smooth muscle. If your mother does not have a higher than normal progesterone level after she conceives, if something goes wrong with that process, her uterus is going to respond to that implementation by contracting, which is going to cause a miscarriage. So progesterone is needed to keep that uterus soft and relaxed. Patients who are lacking in progesterone are frequently supplemented with extra progesterone via shots or vaginal inserts in the first trimester and sometimes into the second as well. HCG, that is your hormone. Remember the normal over-the-counter pregnancy test? Looking for HCG. But the purpose of that sudden huge spike in HCG level is because this hormone stimulates the corpus luteum to produce estrogen and progesterone until the placenta gets big enough to take over and do that function. Here's a little plug for that reproductive PowerPoint up in your lecture self-review module. I would strongly encourage you to get familiar with that if you're not sure about what the corpus luteum means. Next hormone we'll talk about, human placental lactogen, HPL. HPL is produced by the placenta as it gets bigger in that second trimester. The reason for this is as we approach the end of the second trimester, the fetus has to start significantly growing in size. In order to grow, that baby needs more sugar. In order to make more sugar available, human placental lactogen acts as an insulin antagonist. It doesn't work as well, so there's more glucose available for your fetus. Human placental lactogen is one of the reasons why we screen for gestational diabetes at the end of the second trimester. And then we mentioned before, relaxin softens connective tissue. It relaxes those pelvic joints. Be familiar with these hormones and understand how they work in the system and are related to signs and symptoms of pregnancy. A brief touch on the neurological system. During pregnancy, you will occasionally see women lose consciousness. Usually in the second trimester, this is probably related to hormones changes. Remember that sudden increase in blood volume. Remember the problems with supine hypotension. She also has challenges to maintaining a level blood sugar. Her heart is under a significantly increased workload because of the increased blood. She has any underlying heart problems, they may present themselves now. Also anemia. So while fainting can be a neurological issue, it can also be caused by many of the other things going on in pregnancy, which does make this a bit of a challenge. Headaches can happen. It's individualized in women. Some women have migraines that go away during pregnancy. Some women have migraines suddenly occur that never had before in pregnancy. We think it is related to the hormonal changes. Everybody adapts a little bit differently. If I have a neurological system that for some reason is being overstimulated, for example, with preeclampsia or some of the hypertensive disorders of pregnancy, I'm going to have increased reflexes. So reflexes are an important assessment of her neurological system. Remember this when we're talking about assessments and charting. You're assessing her neurological system by doing deep tendon reflexes. Metabolic changes. She needs more calories. Primarily, she needs more protein. She needs more iron. Remember that increase in blood volume. She's going to need some iron to compensate with that. One of the most important things she can do to prevent problems is to stay well hydrated. Another challenge in our area of the country. Her water requirements increase too. In the first trimester, for a patient entering pregnancy with a normal body weight, we expect her to gain roughly 3 to 5 pounds. The second and third trimester, she should average roughly a pound a week. This can be impacted by fluid retention. It's not uncommon for pregnant women to have dependent edema, meaning edema that gets worse throughout the day, is seen in their lower legs, ankles, and feet. At night, they put their feet up and it goes away. That's dependent edema. I have a chart below taken from your text. Be aware that this is not a one-size-fits-all recommendation for weight gain. It very much is impacted by what her status is when she is entering the pregnancy. Women who are not quite so heavy might need to gain more. Women who are already obese might need to gain less. Occasionally, if they change their eating habits, they may even lose weight during the pregnancy. As long as we are assessing fetal growth and that looks good, we can live with that. This is here just to give you an idea of where that weight distribution is going. It is not just about the baby itself. Keep in mind she has more weight because she has more blood. The uterus grows to 20 times its size, so it's going to weigh more. She has increases in breast tissue because of the changes as her body's adapting and preparing for breastfeeding. The placenta itself is anywhere from 1 to 2 pounds. Bigger babies have bigger placentas. Smaller babies have smaller ones. She does have more fluid volume in her system, in her lymphatic system. She may have some edema, again, dependent edema. She is laying down some extra maternal fat stores for breastfeeding, and because our bodies are programmed to do that. Generally, this is going to end up around her thighs and her bum. In some women, they like that. Most women, not so fond. Amniotic fluid itself. Go lift up a gallon of milk. It's kind of heavy. That amniotic fluid is roughly 2 pounds too. All of these things together come out to an approximate total weight gain of about 30 pounds. Some countries suggest significantly less than this. Other countries don't seem to care at all. So because of this changes in weight, she needs to be paying attention to her diet. It is very important that she is eating well-balanced, nutritious meals. There are a lot of theories and ideas about what constitutes a well-balanced and nutritious meal. But we do know that she needs vitamins, she needs fiber, she needs protein. So education, meet her where she's at, see where she can improve. We want her to be taking prenatal vitamins. We do not want her to be supplementing on her own with additional vitamins. For example, vitamin A and vitamin D, mega doses of these can be teratogenic to the fetus. Too much of a good thing. If she's taking prenatal vitamins, that should do it. Occasionally, women will have an urge to eat stuff that is not food. This is called pica. Usually the urge is to eat dirt or starch. Sometimes you'll see pregnant women chewing on ice constantly. That's another form of pica. These is thought to be related to potentially an iron deficiency or some other deficiency in the diet. If we can correct that, the pica may go away. And of course, keep in mind, nausea and vomiting are common, especially in that first trimester. So if you want her to be eating and keeping things down, we need to treat that. Ginger is a very safe and effective method to help some of that nausea. If you're looking for macros, protein needs of a pregnant woman increase significantly. We suggest 80 grams a day. We want extra calcium. The fetus will take the calcium it needs from her bones, so we want to make sure she has a good supply to start out with. Interesting fact, she may be eating for 2, but the actual calorie need is only 300 additional calories a day. That's not very much. She needs to be sure that that additional 300 is coming from good nutritional sources, not empty carbs. A breastfeeding mom requires 500 extra calories a day, so it takes more calories to breastfeed a baby than it does to grow a baby. Folic acid deserves a mention here. The more we study folic acid, the more we realize how crucial it potentially is. We would like women to be supplementing with folic acid before conception, so they have it in their system when that conception happens. This helps prevent neural tube defects. During pregnancy, we want them to take more folic acid. We have found that it is related as the brain grows. Folic acid helps improve those neurological connections the brain makes in itself. That's a real motivating factor to take some additional folic acid. Also, keep in mind that iron, 27 milligrams up from 18. If she's a vegetarian, you need to be addressing ways she can incorporate extra iron in her diet. An example of some dietary sources of folic acid and other awesome vitamins and minerals. Liver, if she tolerates it. Not everybody does. However, the good news is folic acid is also put into cereals and breads in this country, so most things are supplemented with it. A more natural source, if you're looking at a wide variety of colors in fruits and vegetables, she's eating a colorful diet, she's probably getting plenty of folic acid. What should she not eat? There are lots of stories and suggestions about this. Medically speaking, she needs to avoid soft cheeses, such as brie. Sorry, guys. The soft cheeses have an increased risk of harboring listeria. And while listeria can cause problems for mom, it's much more likely to cause significant issues for a fetus. Increased risk of stillborn babies. It's just not a place that we want to go. So that is why we recommend she does not consume undercooked or raw meat. We do not want her to eat sushi. We do not want her to eat soft cheeses. The viewpoint of eating fish has actually changed. We are now strongly suggesting that pregnant women have at least 2 to 3 servings of fish in their diet. Because in general, in America, women don't eat that shark or tuna or fish that has a higher level of mercury in it. When I say tuna, I mean fresh tuna, not the canned stuff. If you're looking at the larger, hard, firm fish, those are the concerns of mercury. If you're looking at the smaller, softer texture white fish, that fish has some great nutritional advantages. We want her to be eating that. So just make sure she understands the difference. Once again, sushi is not included. Sushi is raw and uncooked, so that is prohibited during pregnancy. This slide is here to help you have a place to put it all together. Sometimes it helps you to review and look at everything at once. Take some time on your own, break this slide down. Let's talk about danger signs in pregnancy. Here's where I want you to start thinking about what a nurse would suspect. If my pregnant patient comes in with a gush of fluid, I'm concerned that her bag of water has broken. Now, it is possible for babies to jump up and down on the bladder, but I need to rule it out and make sure that it's not urine, that it's actual rupture of membranes. There are tests we can do to confirm that. How about vaginal bleeding? What if I have a patient come in with bleeding? First off, what trimester is she? What's her gestational age? How much bleeding is she talking about? Vaginal bleeding can be a sign of placenta previa, placental abruption. If it's happening before 37 weeks, she might have a cervix that's starting to change, which breaks little small capillaries, and you usually have some bloody discharge with that. I want to rule out preterm labor. Abdominal pain. Well, this is an issue in pregnancy. Severe, constant abdominal pain can be placental abruption. Abdominal pain that is gradually growing stronger and coming and going can be preterm labor. Sudden couple-second changes of abdominal pain that go away real quickly can simply be ligament stretching. So education is a crucial point in this, so your patient understands what she's looking for and what she can expect to be normal. We discussed the changes in a mom's immune system that make it just that much more important for her to come in and be evaluated if she has a temperature greater than 101. Persistent vomiting. I am worried about hyperemesis gravidarum, which we'll talk about. The difference between persistent vomiting and normal vomiting of the first trimester of pregnancy. Persistent vomiting is continuous. They cannot keep anything down. You're going to teach your patient, if she has not kept anything down for 24 hours, I'm obviously concerned about dehydration. I want her to come in and get looked at. There are some classic signs of hypertension every pregnant woman should know. Visual disturbance, such as blurry vision, little floaty spots in her eyes. Generalized edema. This is different from dependent edema in that it's in the hands and the face. It comes on suddenly and it does not go away overnight. Generalized edema can be a sign of hypertension, as can a severe headache. Patients will usually say it feels different from any headache they've ever had before. Epigastric pain requires some specific assessment so you can differentiate from abdominal pain or heartburn. Epigastric pain is a continuous dull pain right over her liver that might mean that her liver is starting to swell. This again could be a problem with some hypertensive diseases. Pain when she pees is never normal. While frequency might be normal, pain is not. And we've talked at length about how important it is to get those UTIs treated quickly as we can before they can develop into anything more significant. Flank pain. If you have a patient come in and you have any suspicion of infection, tapping on her lower back can frequently get you a sudden jerk and complaint of severe pain. That's what we call flank pain. That's a classic sign of pyelonephritis. Infection that is increasing, we want to get that treated quickly. All of these are signs and symptoms it is important for you to teach your antepartum patient about, so she knows when to come in and get seen right away. Of all of these, probably the most important sign for patient education is decreased fetal movement. Decreased fetal movement can be related to compromised fetal well-being. Who knows what's normal for the patient, your patient. So this is very subjective and is going to depend on her perception of fetal movement and what's normal for her baby. A patient paying attention to her fetal movement and coming in when she has concerns has been found to be a more accurate test than all of the fancy ultrasounds that we have. So we need to pay attention to this one and educate our patients if they have concern, come in and get it checked out. We can do a non-stress test and instantly get more information to see if it's something we need to be concerned with or not. Now that we've talked about the physiological changes in pregnancy, let's look at the psychological response to pregnancy. In our society, we have this picture of what a woman should feel when she finds out she's pregnant. Based on movies and TV shows, very frequently, the assumption of what she's going to feel is that it will be happy, happy, joy, joy, unicorns and rainbows, and everything is fine and wonderful. The reality is that while she may be happy, she may also be very ambivalent. Even women who are trying to get pregnant, once it happens, it's a pretty intense realization. It is not uncommon for her to be ambivalent, to be not sure if this is something she really wants to do, if it's something she can do. It's a little bit of a challenge to her mentally. Once she has settled into the pregnancy, usually moving towards the end of the first trimester and into the second, she begins to accept the pregnancy and get a little bit more excited about it. There are a lot of physical changes going on in her body. There are a lot of potential changes that are going to impact her life in the near future. So it is very normal for a pregnant woman to become a little bit more introverted. She starts to spend a little bit more time on herself. She may withdraw a little bit from other relationships. This would be normal psychological responses to pregnancy. Mood swings. We've talked at length about hormones. Think about all of the additional signs and symptoms that she's having. Throw that in with a lack of sleep and hormone changes, and yes, of course, you're going to have some mood swings there. That is totally normal. Good psychological response. We need to let family members know what to expect, and that's normal too, and how they can help. Changes in body image are another psychological response we need to be very aware of in the medical community. Does she have any type of history of eating disorders? If she does, imagine how losing control of her body and the changes are going to potentially impact that in her brain. Even women without eating disorders, who in the past have found a lot of self-worth and value in how their body appears, can be really challenged by these changes that happen throughout pregnancy. So helping her to see that as a normal and expected change, and maybe even a positive thing, might be very helpful. Of course, we're nurses, so we have theory. Rubin, in 1984, came up with the developmental tasks of pregnancy. These are the psychological tasks that a woman works through as she progresses throughout her pregnancy. Pregnant women, it's very normal for them to turn inward, so they have a subsequent reduction of attention and energy available for other tasks. Again, this is normal. In her brain, she has to come to terms with how she's going to pass safely through pregnancy. She is looking at acceptance of this child by others, family members, grandparents, partners, community. Then she has to adapt to and begin to come to terms with what kind of mother am I going to be? Commitment to this baby, acceptance of the self as the mother. What kind of relationship did I have with my mother? Was it good? Was it bad? What am I going to do the same? What am I going to do different? And last but not least, learning to give of oneself on behalf of one's child. No, this is not always an instinctive response. Some people have more difficulty with this than others. A psychological developmental challenge is to learn to put this baby's needs ahead of your own. As the pregnancy continues and progresses, as she gets closer to the end of the pregnancy and identifies the fetus as a separate part of her, generally this last task becomes more easy. Just so you are aware, Several studies have reported that pregnant women with high levels of anxiety are more likely to experience obstetrical complications. Everything that we can do to encourage therapeutic communication, to help her feel safe and find resources that make her feel like she can do this, that will actually help her medically and physically. She will have a decreased risk of some of the complications that can happen along the way. Please do not discount the psychological responses to pregnancy. They make as much impact on her as any of the other physiological changes do as well. This ends our antepartum lecture. Next, we're going to be talking about high-risk pregnancies and things that can go wrong.